So what I'm going to do is talk about how we can optimize PSMA into our practices. And I'd just like to start out with a couple of generalized statements. And I really think that PSMA is a disruptive technology. When you sort of think about what we've done in urology and where we've come, PSMA really is disruptive. It has a much higher sensitivity than conventional imaging. We'll talk a little bit about that in a moment. It can change management in about 50% of cases. And when you look at it compared to flucyclovine, it's much higher in sensitivity, especially at low PSAs. It also detects sites outside of salvage radiation therapies that can impact treatment. And it's highly accurate for localizing metastatic disease in patients with biochemical recurrence, and we'll talk a little bit about that as well. So I'm going to talk about first PSMA versus conventional imaging, then we'll talk about it with initial staging, biochemical recurrence, maybe talk about risk stratification and outcomes, and then talk a little bit about how you can develop a PET program. If some of you are in academic institutions, this is sort of really not relevant because most hospitals have a program, but we're starting to see large urology practices developing PET programs in their offices, and I'll explain a little bit about that and what's being done. So this is just actually an example of PET scanning, in practices. So we're starting to see an explosion take place, not only as fixed units, but we're starting to see, much like what we saw with lithotripsy. Some of you, when I first started my urology career, the lithotripsers were all put on tractor trailers and brought to different practices. And now that model is being reproduced in practices. But here's a paper looking at PSMA versus conventional imaging, the PRO-PSMA trial, about 300 men with intermediate to high-risk prostate cancer. And the endpoint was the accuracy compared to conventional imaging. And there were some secondary endpoints, comparing to standard of truth with histopathology. But there's some big takeaway messages from this paper that appeared in The Lancet. Number one is PET was about 27% more accurate than conventional imaging. There were fewer equivocal lesions noted, 23 versus 7%. There was higher reported agreement between the radiologists, led to more frequent change, 15% versus 28%. And then obviously there's less radiation exposure. So we have a technology now that is much more accurate than what we've been doing in the past. And I think that we've seen a major change take place. If you look at the evolution of PSMA testing, 1983 was when PSMA was found on prostate cancer cell lines, but it really wasn't until 2014 that we started to see this explosion take place. And then in 2020 was when all the approvals took place. The gallium agent, PYL in 2021, and then you can see lutetium, and then the post-Luma, the Blue Earth product, actually was approved. So if you look at the timeline, here's the gallium product was in 2020. A year later, or half a year later, the PYL, Polarify, post-Luma in 2023. And to put it in perspective, flucyclovine was approved in 2016. So you can see there's this evolution taking place on how these agents have evolved. And understand that the FDA has approved these agents for candidates after initial diagnosis, before definitive therapy, and then obviously the larger group was those with suspected biochemical recurrence. And you can see for those scientists out there, the chemical formulas, you can see the groups very, very similar across the board. Now I put this slide up to kind of demonstrate obviously the initial staging and biochemical recurrence, but keep in mind that whenever you start to see a rise in PSA is when you can actually think about doing imaging. If you look at the guidelines will say at 6 months intervals, but I really think that you need to think about when you start to see these rises in PSA, PSA imaging should come to your mind. Now, is PSMA available to us as practitioners? And here is a large urology group practices across the United States. This is just a demonstration to show they're generated in cyclotrons, and they have a half-life. They have to get to a practice to be injected into a patient. And you can see that the country is pretty well covered. obviously there's some bare spots up in North Dakota, South Dakota, but for the most part, obviously in the larger metropolitan centers, these agents now are readily available and I really think need to be incorporated into our armamentarium. So if we look at the initial staging, you can see that there are the gallium product is on the left. I'm sorry, it's a little darker than I expected. The PYL product and then post-luma. And you can see that the populations for these initial staging patients, 225 to 356. But look at this specificity across the board. It's very, very high, and you can see the specificity and the higher predictive value is really evident in this initial staging population. So what are the kind of takeaways from patients that are from initial staging? Well, there's modest sensitivity for detecting nodes, but a very high specificity that exists. And obviously, the larger the nodes, the higher the accuracy of these agents. The higher the risk of prostate cancer, the higher the detection rates. And I think the bottom line is the train's really already left the station with patient management. This is the current status. We need to integrate this into our practices, for these patients at initial staging. For biochemical recurrence, obviously there's larger populations. You can see the gallium product, the PYL product, which is the offspring trials, and the Lighthouse study, which is the post-luma product. You can see across the board. But the bottom line is, I think that there's similar performance for all three agents. So one agent is not better than the other. Really, the takeaway message is there's really good intra-reader agreement when you look at all these three agents across the board. There's a higher detection rate with higher PSAs, makes sense. Up to 80% of patients with negative baseline imaging have a positive PSMA. So these patient population, especially in the biochemical recurrence, really it's a very significant tool to put into our armamentarium. And again, up to 66% of patients can have changes in their management based on the PSMA scanning. So here's a study looking at 182. This was in JAMA, contextualizing PSMA PET in the current paradigm. You can see these patients, 182 patients with non-metastatic hormone-sensitive prostate cancer by conventional imaging. You can see that when PET scanning was done, at least in this study, PET positive was 84% and polymetastatic disease was 24% of the patients. When volume is from conventional imaging, here you can see on the left, you see conventional imaging, high volume, low volume, and then when you do PET imaging, you can see that there's a significant upticking in detection of high volume disease. And here's an example of a patient that has low volume disease by conventional imaging, and you can see significant high volume disease with PET imaging across the board. Finding the predictive value and essentially using PSMA PET as a prognostic indicator for medium-term oncological outcomes. Here you can see this is from Hoffman in 2024. Looking at this, and you can see the hazard ratio of 1.99 following these patients with nodal disease compared to non-nodal disease here, and trying to predict outcomes in these patients. In biochemical recurrence, if we look at, can PET stratify medium-term outcomes in patients? And the bottom line is yes, you can see there's a significant difference in looking at freedom from progression when compared to PSA, that PSMA is a stronger indicator of freedom from progression than PSA in these patients. And here you can see the PET positivity is the independent predictive factor for freedom from progression in men that underwent salvage radiation therapy. SUV corresponds with biochemical recurrence. It seems to make sense that as the higher the Gleason score, the higher the SUV max will be in these individual patients. And then this is an interesting study from Rob Reiter at UCLA, looking at PSMA, looking at adenocarcinoma versus neuroendocrine prostate cancer. You can see that there's a much more higher uptake with PSMA compared to neuroendocrine prostate cancer. And then another predictive study looking at high PSMA associated with cancer response to salvage salvage hormonal therapy. You can see here 178 patients, those patients that had high PSMAs compared to, it's a retrospective study, received salvage radiation therapy and no pelvic radiotherapy. These patients with high PSMAs did better with salvage ADT across the board. So if you're looking at PSMA and trying to think about how to integrate it into your practices, obviously at larger academic institutions, this is part of the radiology department. But I think now we're starting to see urologists become innovative in trying to integrate this into our practice. And there's a number of concerns with regulatory issues, obviously construction, credentialing, radiology support, and so on and so forth. But the question is you need to know your volume if you're trying to integrate this into your practice. We have a practice of 33 urologists. PET PSMA scanning is available at the hospital, but we decided to see if we could integrate this into our practice. We have to understand what the initial staging versus the biochemical recurrent patients, what these numbers are, looking at the payer mix. And obviously there's a reimbursement for the technical portion of the scan, and there's a reimbursement for the tracer. And you need to understand how this works and how this all integrates with one another. There are some regulatory hurdles. If you're going to do this, you need to have a radiation safety officer. You have to have physics services available. You need to know which tracers are available. Our tracer comes from Albany. We're in Syracuse. It's about a 2-hour drive. But you need to know when these agents are going to be made. For example, if Clarify is available at 10 o'clock, you may get the gallium product available at 8, the post-luma at noon. That's going to be very critical because when the injections take place, you need to know when that's going to happen across the board. And obviously, there are some opportunities with Pluvicto, I think, in the horizon. The one thing that I do think that this does is it does allow for continued continuity of care. There's no, seamless, it's seamless, there's no waiting at a hospital or an imaging center, and there is reimbursement that can be profitable for a practice. The question is you need to know about getting the equipment. You need to know the cost of the tracers are about $5,000 depending on the rebates that exist. Are you going to construct an in-house system, or are you going to allow a trailer to come and be in place? And there are turnkey operations that are available. And the question is what's the break-even number that you need to know if you're going to endeavor in trying to start up a PET center in your practice? What's that magic number to break even after all the expenses are done? So what defines a successful project? Obviously, you need to look at all the expenses and all the income that will come in. What's that breakdown value or that break-even point? And I think most proformas suggest that it's about 25 scans. So if you think your practice orders 25 scans or more, there's probably an avenue in which you can create a system that will be somewhat profitable for a practice. Obviously, 37 scans per month, you can see the revenue can be about $100,000 plus. If you bump that up to 50 scans, you can see that that's pretty significant. So here's a simple proforma looking at 40 scans per month. If you order 40 scans per month, the technical reimbursement's about $1,500, $1,600. The reimbursement for the tracer is about $727. So it's about $2,300 per scan. If you multiply that times 40, you come to about $92,000. Now, you have to take away the expenses of the staff and so on and so forth. So obviously, it's going to be significantly less than that. But that just gives you an idea of what technically you could do in a practice. Now, there are turnkey operations that are available. Captive is a typical partner. Essentially, they bring in all the equipment on a tractor trailer. They have the hot lab. They provide the staff. You, as a practice, provide scheduling and billing and obviously having a radiologist to interpret this. But the takeaway message is 50% of the profit that's brought in is given to the vendor that brings the tractor trailer in. So you can see that, if you want a turnkey operation, the work on your part is significantly less, but it does reimburse you a portion of money. So when you look at where PSMA is, obviously it's much more accurate. It's changed management strategies. There are significant outcomes that can be used to measure what we can try to predict these patients to be. But now we're starting to see new randomized trials in biochemical recurrence. There's a number of trials that are being done across the board looking at this patient population. And here you can see is a multi-center phase 2 trial, PSMA, looking at low-risk early biochemical recurrence. More of these studies, I think, are starting to be done across the board. So in summary, I think PSMA PET is the standard imaging for now initial staging and biochemical recurrence. It frequently leads to changes in management. It has predictive outcomes for medium-term outcomes in patients with prostate cancer. And there are multiple randomized trials trying to assess PSMA PET in management and outcomes in patients. Thanks.